Welcome everyone. Welcome to this afternoon's presentation. My name is Jenny Phillip and I'm the Chair of Palliative Medicine at the University of Melbourne, St Vincent's Hospital, and in collaboration with the Victorian Comprehensive Cancer Centre. And I'm very proud to be hosting this event on behalf of our group of particularly fine people who make up Palliative Nexus. Palliative Nexus is a research group whose goal that all with illness receive high quality palliative care that's equitable, timely, and delivered as a standard of care underpinned by evidence. To begin the proceedings this afternoon, I wish to acknowledge the traditional custodians of the land on which we're hosting this event, the Wurundjeri people of the Kulin Nations, and acknowledge their elders past, present and future. And I also wish to acknowledge any Indigenous Australians who may be in the audience today. Today, we're very excited to be launching our Pal-spectives broadcast series. This was really conceived as a way to keep to date, to develop professionally, to learn from each other, and to keep connected as a field, particularly in these really uncertain times. The Pal-spectives series is taking on two formats. One, which is we're having today, which is on research, which is really a research update from world leaders in the field, hearing about their work, their research findings and their programs. And the other format is Pal-spectives in conversation, which will be an interview or sort of a broad-ranging conversation with key leaders in the field or associated or interfacing with the field, hearing about their career course, key decision points, and also reflections on palliative care. So we're excited that this is happening, and we're very excited today to be launching this, a research update. And I wanted to just highlight a couple of things. One is the format of today's presentation will be a presentation from Professor Merryn, Gott, followed by questions, and you can put your Q&A questions in the Q&A portal, which is at the bottom of your screen. I also want to draw your attention to the Twitter handle, which you can see there. So it's my great pleasure to introduce Professor Merryn, Gott, and I couldn't think of a better leader to launch us and get our series started. Professor Gott directs palliative care and end-of-life research group based at the School of Nursing. It's from Auckland, New Zealand, that she's joining us today. Her group really undertake a range of projects which focus on exploring the social determinants of end-of-life experience and use creative research methods to support the real-world impact of their work. Professor Gott, who's giving her talk today entitled, "It's What Any Good Wife Would Do, Unpacking the Intersection Between Gender and Palliative Care." Thank you, Merryn.
Well, thank you very much. Tēnā koutou, tātou katoa. Good afternoon, everybody. It's really great. It's a pleasure and a privilege to be launching this series and to be connecting with you today. I'm not sure I'll ever get used to connecting with people in this way where we can't actually see each other, but I guess this is the world that we're living in at the moment, and it does give us more opportunity to connect across distances. So just a couple of things to start with. I will put our slides onto the TRI research blog, the slides I'm presenting today. So they'll be available for you if you want them. And I know there's some tweeting and some tweeters present. So if you want to tweet, there's my hashtag. So to start with, I think it's really hard at the moment to talk about anything without mentioning the context of COVID. I know my thoughts have been with colleagues in Melbourne and Victoria over the last few weeks, and I know there's issues in other parts of Australia. You might have heard that overnight we went into lockdown in Auckland. So I was planning on doing this presentation at work, but I couldn't go into work. So I've been frantically looking around the house for somewhere to do it. I've got my daughter doing her piano lesson by Zoom at the same time. So I hope you can hear me and I hope that it's clear. And I know this is just the reality for all of us at the moment. So I think we're all just trying to do our best. So I think one thing that the pandemic does highlight is the impact of inequity within a health context. It's been really devastating to see the unequal impact that the pandemic is having, particularly upon our minoritized communities, and particularly among people who are already faced by issues such as socioeconomic hardship. Within the context of what I'm talking about today, it's also been apparent that women have been disproportionately impacted. There was a report out in Aotearoa, New Zealand last week showing that, for example, of the job losses that have been related to COVID, 90% have been amongst women. So we're really seeing how the pandemic is exacerbating existing health inequity. And I really think that, you know, for palliative care, there's a real message that we cannot continue to ignore the social determinants of end-of-life experience, but we really need to be looking at them in all their intersections as we move forward. And that's really what my presentation today is. It's a call to all of us to think about, in this context, gender as one of the key social determinants of palliative and end-of-life care. And what I want to argue is that we shouldn't be approaching this as a discrete research field, and certainly not just as women's issues, but this should be one of the things we're thinking about, whether we're doing research in laboratories or with patients or in communities. It's an issue that cuts right through. Because I agree with the words of Sir Michael Marmot, who's obviously done a lot of work around the social determinants of health. You know, that health inequalities and the social determinants of health, they're not just a footnote to the determinants of health, they're actually the main issue. And I think that holds true within palliative and end-of-life care as well. So I'm fortunate to direct the TARI research group. As you've heard, we're based in the School of Nursing at the University of Auckland. We're a bicultural research group supported by a group of kaumatua or Māori elders. And really the focus of our group is to draw attention particularly to the social context of dying. Where a lot of our work comes from is from the position that there has been a systematic and I think largely unconscious neglect of the social determinants of end of life, including gender, in palliative care research, practice and policy. And we really believe there's an urgent need to attend to these alongside the sort of more clinical work that we're doing if equity at end of life is to ever be realised. We also believe strongly that solutions have to be formulated and where possible led by people with lived experience. And we believe strongly that we need creative ways of making sure that people's experiences are foregrounded. So we use a lot of creative research methods, and I'll share one of the things we've been doing with you here today. So I think we need to start by thinking about what we mean by gender. I'm sure, you know, this is not new to many people, but I think within the field of palliative care, it's not something that we've talked much about. And really what I wanted to highlight is that, you know, gender refers to the socially constructed nature of difference. So we talk about sex in relation to biology and gender more in relation to the wider social context. And just to give you an example of how gender is socially constructed, how it's fluid, we now think of, you know, boys and girls being encoded as blue and pink. Certainly if you try and buy baby clothes. When I had my twins 14 years ago, I had a boy and a girl, and it was really hard to find any clothes for them that weren't blue or pink. But interestingly, in the Victorian era, actually pink was a very masculine colour, and it was only over the 20th century that changed. So we can see that ideas around gender, about what it means to be a man or a woman, are very contingent upon time and particularly upon culture as well. And I think that's something we really need to recognise, that there is this fluidity. I think the other thing that we really haven't got to grips with within palliative care research is the fluidity of gender identities. And certainly there's been very little research that looks at transgender people, about the issues for the end of life. And certainly I think that's an issue that we really need to be thinking more about in the future. And I won't really talk to this. I'm going to focus predominantly on the women's experiences, but I think this is a real priority area for palliative care research moving forward, because we really just know so little in this space. So I would really, if there are people out there who would like to do some research in this area, I think it's hugely important as we move forward, and that we move beyond this binary of men and women, to acknowledge the fluidity of gender identities. I think the other thing that's really important is that we don't just consider social determinants of end-of-life experience like gender in isolation. As Audre Lorde argued, there's no such thing as single issue struggles, because we don't live single issue lives. And certainly what we've seen in the gender space is that if there is a focus on gender which does not acknowledge intersectionality, then it tends to be the experiences of white middle-class cis women that are foregrounded. And this is apparent in lots of gender equity schemes that have been implemented. So I think it's really important when we're looking at this body of work to recognise that gender intersects with other axes of potential oppression to determine an individual's experience. So within my research group, because we are bicultural, we draw a lot on Māori values, and we use a lot of storytelling in our work. We see stories as really important forms of both research and the dissemination of research. And in line with the Māori values that inform our work, we see stories not just as conveying information, but also as conveying values. They tell us about how we see ourselves within the world. And so I was invited to give a plenary at the EAPC in Berlin last year about gender. And I thought really carefully about how I could convey ideas about gender in a way that was both compelling and also would really speak to people and resonate with their own experiences. So I did a wide scoping review of the literature with colleagues, and from that identified what the key issues I wanted to highlight were, and then I wrote a monologue. And the monologue we called Vivian's Story. And so Vivian was an older woman who lived in Sheffield. We made the decision, because we were speaking to a European audience, that the story should be situated within a UK context rather than within a New Zealand context, because we have had experience of people saying, well, that's just what happens in New Zealand. And also the evidence we were drawing on was not from New Zealand. So we decided to create this story. I wrote a monologue together with my colleague, Dr. Lisa Williams. We worked with an actress to record the monologue. And I played that at EAPC, and it seemed to really have resonance with people and was quite powerful. So when I got back to New Zealand, we talked about how we could build on the work that we'd done and, think of even more ways that we could get this message across, because it really seemed like an important message that people wanted to hear. So we worked in collaboration with a very talented graphic artist colleague called Dr. Tatiana Tavares, and she created a graphic novel based on Vivian's story. And so what I want to do now is to play you a short film that combines the monologue with some of Tatiana's beautiful drawings. And as I'm doing that, and as you're hearing the story, I want you just to think a little bit about the ways in which Vivian's story is gendered, and then I'll talk a little bit to that. So hopefully this will work.
It's been easier since Jack died. Oh, those last 4 years were hard. Jack up and down with his heart failure. There was always so much to do. Appointments, medicine, cleaning, shopping, cooking, checking, worrying, constant worrying. I was exhausted, though I never let on, because that's what I signed up for. A wife looks after her husband, full stop. I neglected my own health, and so I guess that's what got me into the mess I'm in today. I finally made an appointment to see my GP, Dr. Wilson. When I got to the doctor's, I found out Dr. Wilson had retired. I saw a locum instead. Maybe I downplayed the pain too much, because she wouldn't refer me to a specialist. She said, "You're an old lady and they won't do anything about it." A week later, I felt the pain so bad, I wanted to scream. I went to the emergency department, and they ran some tests right away. The results came back, and my GP called me in. It was bladder cancer. There's no treatment we can offer you, he said, but we can refer you to palliative care. I had no idea what that meant, but I nodded and said thank you. Next, a lovely nurse came to see me. She asked me what my main concern was, so I just said I felt tired all the time. She said she didn't think there was much they could do about the tiredness, but she did say I should see my GP to talk about making an advanced care plan. I wasn't that keen, to be honest. I did make an appointment, though. We talked about how I didn't want to be a burden on my family. Some of her questions were easy, like, no way do I want to be resuscitated. Harder was telling her where I wanted to die. Well, home, obviously, but who's going to look after me? My only choice will be to go into a care home. At least when the time comes, I'll be warm there, and there'll be someone to talk to when I feel lonely.
So I'm sure you'll have seen that there are many ways in which Vivian's story was a product of her gender. I think when we think about palliative care and gender, a good place to start is caregiving, because we know that most caregivers are women. A recent survey in the United States, for example, found that 75% of all caregivers are women, and women spend up to 50% more time caregiving than men. And women are also more likely to undertake intimate tasks of caring and less likely to seek and accept formal help. And I don't think it's controversial to say that women's caring work is often invisible, and it's certainly economically devalued. The academic Marilyn Waring, New Zealand academic, has said that the success of the global economy rests on women's unpaid work, but it is systematically ignored and undervalued by traditional economic measures. We know that there are lots of positive associations with caregiving, but we also know that women who are caregivers report higher levels of mental and physical health problems and are more likely to live in poverty than male caregivers. We also know that there's an intersection between gender and biology, and this is also apparent related to caregiving. But a recent study that you might be interested in looked at telomere length in relation to stress, and found that major stresses actually had a significant negative impact upon telomere length. And for the social scientists like me amongst you, that just means that's a bad thing. But what was really interesting was that this could be mitigated by positive health behaviours. And again, that brings in intersectionality, because to be able to engage in positive health behaviours, to be able to go to the gym, to do yoga, to eat healthily, often can cost time and money. So you can see that there's really complex ways in which sex and gender intersect to determine women's experiences. There's a mounting body of evidence, a few studies really coming out to show that there's increasing pressure upon caregivers to try and realise death at home as kind of a marker of a good death. And there was a really interesting study that came out of Canada not so long ago, which looked at this very thing. And the study found that a lot of the women caregivers felt that they'd failed their husband if they hadn't managed to achieve that death at home. And I think given the current context of COVID, the increase in end-of-life caregiving, I think the issues we have with being able to provide really good support for caregivers within the community, and the drive to try and increase deaths at home, I think it's really important to recognise this gendered aspect that is going on. And by saying all this, I don't want to imply that men aren't caregivers and don't provide important care. I'm just trying to show how caregiving is gendered. Vivian talks about the pain that she experienced and tells a story about not being able to be referred, not being offered a referral for help with that. And that's actually word for word a story that we've heard in our research. And it's not surprising because actually there's a long history of women's pain being devalued. And what's interesting is that this shows out both in clinical studies. We know that women wait longer to receive analgesia, for example, when in relation even to things like symptoms of cardiac problems. But we also know that actually the very basis of a lot of the medicines that we use in palliative care is flawed when you look at it from a sex and gender perspective. And there's been some really interesting work that's been done looking at the fact that we're using male animals in research and not female animals, and that's because female animals are perceived to be too messy because they have ovaries. And there's an increasing number of women, so unsurprisingly, researchers talking about the impact this is having on the field and on the actual drugs that are coming through in the longer term, and that we really need to be considering the gendered nature of pain and the treatments that are given for pain and the management that people experiencing pain receive, which I think is really fascinating and definitely an area which requires more research. Vivian talks about her palliative care referral. Interestingly, there's evidence that women are more likely than men to accept and to receive a palliative care referral, and I'll talk about some things in a minute that might explain that. But I think what's less talked about is actually that women are less likely to benefit from a palliative care referral than men. So this comes from the secondary analysis of the Temel study. So I'm sure you all know the Temel study, really famous, received over 5,000 citations, has had a real impact within the field, leading to calls for early palliative care intervention. But there was actually a secondary analysis of those data that showed actually that benefit only accrued to men and not to women. And I was really fascinated and actually really shocked when I realized this when I was digging around in the data to give this presentation, because actually this is something that we don't talk about at all within palliative care. And certainly when I presented it at the APC, people were really shocked. So I think, you know, there are these gendered issues going on within the research that we're doing. And, you know, we're reporting the data, but actually no one's picking up on it. So I think, you know, this is something we really need to be aware of. We can't carry on talking about sort of one palliative care patient as if they all shared the same characteristics, including the same gender. There's interesting research about women in relation to end-of-life intervention and gender. So Vivian talks about not wanting to be resuscitated, and actually there's a body of evidence to show that women are less likely to opt for options such as resuscitation and also life-prolonging treatments. I think this is really interesting as well, because it brings into perspective the fact that actually the gendered nature of end of life is bringing disbenefit, not just to women, but also to men as well. So we know that men are more likely to receive CPR. So there was a study showing even amongst people who fall down in the street, men are more likely to be resuscitated than women. Obviously, we can't say whether that is a good thing or not, but I just think it's really interesting that that's happening, and that goes all the way through as well. Men receive more ICU admissions, and there was also a study showing that men receive more chemotherapy right up to the end of life. So there's all these gendered issues going on regarding the sorts of treatments and interventions people are receiving. And I think we really desperately need more research to understand, crucially, to what extent this is in line with what people themselves want. So Vivian talks about wanting to die at home, but she's quite realistic in realizing that actually she has few options to do that because she's quite socially isolated. And she talks about the fact that her only option will be to go into a care home. And that's quite realistic, really. There's been recent research, for example, in Aotearoa, New Zealand. We have one of the highest rates of people dying in aged care in the world. And if you're a woman of 85, you have over 85, sorry, you have 62% chance of dying whilst you're resident in aged care. And that compares with 52% for men. And it does make me wonder, we know our aged care facilities are undervalued, and I think we're really seeing that at the moment. And you do wonder, because there's a predominantly female resident base, they're staffed exclusively by women, whether there's some sexism as well as some ageism going on in the way that aged care facilities are viewed within our society. I just wanted to finish by talking about one issue related to the intersection between gender and another social determinant of health, and that's poverty. So this is something I've been really interested in for a long time now, and it actually stemmed from when I was working in Sheffield, and I was a research assistant going around interviewing people. And I had, I think, quite a naive view around dying at home always being the preferred option. And I remember talking to a man who was living in a cold house, who didn't have enough food in the fridge, who talked quite openly about that, and saying, I presume you want to die at home. And him saying to me quite categorically, my house is not a nice place to live, let alone a nice place to die. So it's made me really interested in how we actually think about serving the needs of people who are living with poverty. And I've currently got 2 studies that are exploring that, one in collaboration with Dr. Naomi Richards. She's leading that out based at the University of Glasgow. And we've just received a grant in New Zealand, together with my colleague, Dr. Jackie Robinson, to look at palliative care within the context of deprivation. But I think what's really interesting is that we know, this quote here is from a recent report from the UK, and we find similar data everywhere, that older women are more likely to be poor, socially isolated, to be poorly housed, unhealthy, and to die sooner because of a cumulative impact of unequal pay and unequal working conditions, including carer responsibilities. So I think that just gives you one example as to why we can't just think about gender in isolation from thinking about other factors. So I'm aware that my time is nearly up, and I'm looking forward to receiving any questions that you might have. But I put up this slide to remind me to tell you that all the work that I am talking about here, and I've only been able to give you a little bit of a snapshot of what we've been doing, but we've just written this up for publication, and hopefully that will be out soon. And everything that we publish we'll put on the TRI blog. So if you're interested, do subscribe to the blog and you'll find out when this is published. And I just thought I'd, reiterate what we said at the end of the paper, because what I'm really arguing for is a paradigm shift in palliative care research, practice and policy to incorporate a focus on gender. And I think crucially, this applies to us wherever across the continuum we are doing our research. We also believe that we need to recognise that gender is something which is performed, it's not innate or natural, and that we always need to adopt an intersectional approach, because otherwise we will be promoting only the interests of white middle class cis women to the detriment of others, without meaning or wanting to. That there's a lot of evidence that that is what will happen. And we need to consider how gender operates beyond a binary system as well. As I said, I think this is an urgent area for future research. And ultimately, I think continuing to be gender blind will continue to perpetuate the white middle class man's experience as the objective norm. And ultimately, that takes us further and further away from, I think, what we're all trying to achieve, which is equity-focused palliative care. So I think my time is up, and that's all that I wanted to say. So here's a link to our blog again, and there's my email address as well. But thank you very much for your time.
Thank you, Merryn. Thank you for a terrific presentation. I'll just remind the audience, while you're just collecting yourselves audience, is that you can put your questions on the Q&A function at the bottom of your screen. But really, Merryn, thank you for that. I guess, really placing this in the broad contextual sort of societal issues, and then giving us a deep dive into the intimate, deeply personal impact on individuals. So thank you. I might kick off the questions, if I may. And in a way, it's a comment, but I'd like your reflections on it. It seems to me that the invisibility of women as carers is heavily relied upon by our systems at the moment. And, you quoted Vivian, and we've had similar people who've looked after their partners with COPD for many years who don't necessarily, want to be doing it. Some do, some don't. But that's just their job. And I'm just wondering how, I guess the question, how confident we can challenge this when the system is so heavily reliant upon it.
Yeah, so that's a really good question, and it's something that I've been thinking about for a long time. And what I decided together with colleagues is one way we can do that is to actually try and quantify that contribution economically. So I've been working particularly with my colleague, Dr. Claire Gardner, who's at the University of Sheffield, to do work related to the economic costs of family caregiving, which we know is predominantly a female-based job. And we've recently been set up a task force under the EAPC. So there's a group of us, including researchers from across the world involved with that. And we hope that by being able to progress that and to put some numbers around it, that might help us move forward. Because I think you're right. I think it's politically expedient for this work to be invisible. So it's very hard to get it on anyone's agenda.
Thank you. One of the questions from the audience is, one palliative care doctor I've worked with described that the chances of dying at home was directly proportional to the number of daughters the patient had. Found this to be generally, sadly, true. Any thoughts?
Yeah, I mean, I think from the work we've done that does have a lot of resonance. And certainly when there seems to be a gender division of labour, and I'm not wanting to generalise, but this has come through in the research that we've done, that sons would be more in charge of the financial aspects and the legal aspects, and daughters more heavily involved with the physical and the sort of more emotional aspects of caregiving. So, I mean, it's interesting to think how this is going to unfold moving forward. I'm also aware that there's a growing number of women who are, not having, without children, unmarried, potentially, who are living alone. And so it's, we have to think a lot more creatively about how we can support people, whether they have daughters or not, to realise the end of life that they want to.
Thanks, Merryn. And a question from Amanda Ormerod about any suggestions in the ways we can improve outcomes for women in palliative care. Might be a big question, but perhaps if there was one or two thoughts that you had.
Yeah, I think it's a really important and big question, and obviously there's not one answer. I think, at a policy level, we could do more around supporting caregivers. So that could be one thing that we look at. Certainly countries like Canada, there's more generous paid leave entitlement for caregivers. And I think this could really support a lot of women who are caregiving. In terms of the other outcomes, I actually think we need to understand more about how some of these actually play out for the individual. So we know from the evidence, for example, that men are getting more ICU admissions, women are getting less, men are getting more resuscitation, but how does that actually play out in terms of what the individual actually wants to happen to them at the end of their life? So I think that, I just feel like there's so much research that needs to be done. But I think in the first instance, just talking about it and recognizing it. When we do research, I think, we're not very good at picking out and looking at differences like gender and other differences. So I think we just actually need to start really looking at it and talking about it and understanding it. But big issues moving forward.
Yeah, thank you. I was challenged hearing you talk in Europe of thinking about the clinical trials that we're doing for symptom management drugs, and I don't know if there's a gender difference in the outcomes. From Odette Sprite, great, thank you for your great talk. Are there any areas where women have an advantage in palliative care context? And women tend to outlive men, and this obviously affects their end of life care.
Yeah,
I mean, as reflected, but
no, I'm just wondering, I mean, an advantage could be that we're getting less aggressive end of life intervention. I think that could certainly be an advantage. Yeah, I'd have to think a bit before answering that question without making some flippant comments about.
Yeah, perhaps maybe it's a good comment and one.
It is a really good comment. Really good comment. Thank you.
So from Beth Russell, who's asked a long question. Thank you, Merryn. This is really fascinating. Can I ask you to share some of your experiences and tips in how this paradigm shift has played out practically in your palliative care research so far? Do you try to hold gender-specific focus groups for qualitative research, or add additional gender-focused questions, for example?
Yeah, that's a really good point. So I think we're definitely attending to gender in a way that we didn't before. We haven't actually got any funded work that's looking specifically at moving this on empirically. We're doing more work with the novel and with evaluating that and getting people to talk about gender. But my colleague Tessa Morgan, she's doing her PhD at Cambridge, and she's doing some really excellent work about caregiving amongst husbands and wives of sort of an advanced age. And there's some really interesting gender aspects coming out. So, I mean, I think it's really complex as to how we research it, and I don't think there's any one right way, but I think it's really just when you look at, I mean, when I look at transcripts now, I look at it through a completely different set of eyes, because I'm just so aware of what is gendered and what isn't, and just being aware of it, I think is the first step. And then, you know, moving forward, what we need to do methodologically, I think that's really interesting. So thank you for raising that.
Thank you. And perhaps sort of building on that, another question was asking about identifying or testing solutions, and one thought was whether there's some work in the compassionate community space that you're aware of.
So I'm not aware of any work specifically. I think I've certainly talked a lot about gender within that space, and how we have to be careful that community doesn't equate to unpaid women's work. So I think, again, just being really attentive. And it's also, I think, just really being really important to start with the experiences and the perspectives of the people most affected, and not putting our own views on top of that. And just to give you one quick example, we did some work with some Pacific women caregivers to create a resource to support them in caregiving. And, you know, we thought, oh, well, they want a leaflet, they want a website, maybe they want an app. And what they actually ended up creating was a music video, because they wanted to raise awareness of women caregivers within their community. And that was completely fascinating, because that would never have occurred to me. So it's just really sort of driven home to me how important it is for us to put our assumptions as to what people need to one side, and just give them the space to talk about what it is, and to acknowledge that there's huge diversity.
Gosh, thanks, Merryn. There's so many questions. I'm being overwhelmed, but it's fabulous. One question has come around, is there any data that you're aware of on single women who've never partnered?
Yeah, not. I haven't looked.
A different sort of end of life course to I guess what we've been, I guess, mostly talking about. Yeah,
absolutely. So not off the top of my head. There is quite a lot of work in the aging space now. That I've got a colleague, I can't remember her surname. I can provide you with the information, but she did her PhD thesis, Ruth Allen, that's it, sorry, Ruth Allen, who's University of Auckland, and she looked at the experiences of childless women in relation to their expectations of aging. So I think there's actually a lot in the gerontology literature that we can learn from, and certainly they've been way ahead of us in attending to gender, and there's a whole sort of subsection of feminology. So I think in that work there definitely is something, and there might be something that I just can't remember or don't know about. But I think again, it's a really important issue for us to be thinking about.
Yeah, there's so many sort of areas that invite lots of questions. I will make this the last question, and sorry to everyone who haven't actually had their questions directly addressed, but do you have any perspectives on the challenges for palliative care as a sector, given the vast majority of workers within the sector, and including also, I guess, aged care, are women? So what are the particular sector challenges, given this is largely a predominantly feminised workforce?
Well, I mean, I think that's a great question, and it depends at what level you look at it, because there's obviously lots of different challenges. I mean, COVID's brought into context the fact that women are juggling, and particularly childcare and work, and so I would imagine that will have a particular impact upon the palliative care population in the way it wouldn't upon a male-dominated profession. I think unfortunately there are issues of status as well around, the status that palliative care is held in, sadly. I mean, I work in very women-dominated areas, and I sometimes get challenged about that. And I'm like, well, if you paid nurses more and palliative care was, had the same status as surgery, then actually there'd be a lot of men in it. So, yeah.
Yes, it's throughout. It threads throughout, doesn't it? Yeah. So, Merryn, there's been a number of comments on the chat as well, saying fabulous talk. So, I will start to draw this to a close, and really, I guess, just echo that again. Thanks for a wonderful, thought-provoking, and very rich presentation today. We didn't even get on to talking about the wonderful media that you're using to disseminate your research findings, and I would like, to formally invite you back to have a talk about that sort of more fully. But we're very excited about that, and we're so excited that you've been our inaugural launcher of our series. So thank you for performing that role so adroitly. I would like to draw this session to an end, and just to let you know that a recording of this will be available on our website, and also on Merryn's website, as she indicated. I'd like to, in addition to thanking Merryn yet again, I'd also want to thank the behind the scenes team, particularly Tanya Fraser, who makes all things happen, and also Stacey Panozzo, Anna Collins and Rachel Coughlin, who've been really the masterminds of this Pal-spectives series. Thank you to you, the audience, for tuning in and for your terrific questions and for staying engaged and being part of this, our first session. And I guess just to conclude, I wanted to highlight that we have the next Pal-spectives coming up, which, as said, will be an in-conversation. And that will be held on the 23rd of September at 4 p.m. and will be a conversation with Dr. Frank Brennan, who many of you know, which will be rich and joyous and also full of lots of interesting insights. So I hope you'll join us then. The registration will be soon available on the website. So thank you everyone for your attention. Thank you, Merryn, once again, and good afternoon, everyone.
Thank you.